It's now my pleasure to introduce Karen Moffat as our next speaker. And Karen is a technical specialist in the Special Coagulation Lab at the Hamilton Regional Lab Medicine Program. And she's an associate professor at McMaster University in the Division of Hematology and Thromboembolism. Karen holds an undergraduate degree in education with specialization in adult education from Brock University. She also holds a Master of Science in Health Research Methodology from McMaster. Karen has been involved in many guideline preparations and best practice recommendations. And it's our pleasure to have her here today to talk to us about what core labs we should be monitoring when patients are on the different anticoagulants. So thank you, Karen.
Thank you. Thank you very much. It's a pleasure to be here and to see people in person again. So I do appreciate the invitation and the organizers for inviting me today. I don't have any, these are my disclosures. My only disclosure is I am Vice President of Member Engagement for the International Society of Laboratory Hematology. Otherwise, I don't have any disclosures. I am to state that I am eligible for an honorarium for today's talk, as well as the companies listed may benefit from sales of products discussed in this program. As we know, Thrombosis Canada has done an excellent job of mitigating potential bias through appropriate review of the curriculum. Today's talk is going to discuss the principles of core and special coagulation laboratory assays and their use in monitoring anticoagulants, and the influence of the traditional and newer anticoagulants on coagulation laboratory results. As we know, the traditional anticoagulants of warfarin and heparin have been around for quite a while. Warfarin is a vitamin K antagonist and inhibits the action of the vitamin K dependent coagulation proteins that include the factors 2, 7, 9, and 10, as well as our natural inhibitors, protein C and protein S. Heparin, we generally have the two forms available, unfractionated or standard heparin, which has to form a complex with antithrombin, and it catalyzes the inhibitions of both factor 10A and thrombin. Low molecular weight heparin is a smaller form and has a higher target towards factor 10A than in thrombin. If we think about the laboratory tests to monitor warfarin, that is the Prothrombin time. And the Prothrombin time is a one-step reaction where we take one part of the patient's plasma and we mix that with 2 parts of a PT reagent or a thromboplastin. The thromboplastin contains 3 things: tissue factor, in order to activate factor 7 to 7A and to form a complex of tissue factor 7A, as well as a source of calcium, because to form our prothrombinase complex, we have to have the surface calcium in order to bridge, or we have to have the positive charge of calcium to bridge onto our phospholipid surface. When we collect samples, when you order coags, we do collect into a sodium citrate vacutainer, which chelates our calcium from our plasma, thereby preventing blood coagulation. As well as when the plasma we're testing is what we call platelet poor plasma, which is a very low platelet count of less than 10 times 10 to the 9th per liter. And therefore, our reagents in the lab have to replace both the calcium and the phospholipid that is normally available for coagulation testing. In addition, all commercial thromboplastins have a heparin neutralizer. And this heparin neutralizer is still there to this day, even though your use of unfractionated heparin is not as high. And that is because the prothrombin time is used for monitoring warfarin. And because warfarin is a vitamin K antagonist, that takes time to bring down your factors. So you're bridging with a heparin. And so the powers that be many years ago went to the manufacturers and said, we want the heparin effect removed from the prothrombin time. Therefore, we have this heparin neutralizer in the reagents. This results in a PT in seconds being determined. For warfarin monitoring, we have moved to the international normalized ratios in about 1998. And I'm old enough to remember that transition. And so we transitioned to reporting the PT in the INR. And I'm going to get on my little soapbox because the INR is not a laboratory test. The INR is the reporting unit of the prothrombin time in seconds. All right. So I get off my soapbox very, very quickly because I'm just as guilty as calling the PT the INR as everybody else in the world. But it is a reporting unit of the PT in seconds. It is a mathematical equation where we calculate the PT ratio of the patient's PT in seconds divided by the mean normal of a minimum of 20 normal patients who are not on anticoagulant. And we take that PT ratio to the power of the ISI. So what I always remind the residents that I'm teaching is this is a to the power equation. It is not multiplying by the ISI. And the ISI is the International Sensitivity Index. And this is a conversion factor that takes our lab reagent back to the World Health Organization's referenced tissue factors. They have WHO has two referenced thromboplastins or tissue factors. One is rabbit and one is human. And labs, depending on which tissue factor they're using in their PT reagent, compares to that one. And the ISI for our local reagent or the local lab that you're dealing with brings in calibrators and compares back to that WHO reference. And so the ISI brings us all back to that WHO reference. And this is where we get that international harmonization, if you will, by reporting the INR. It's an inverse relationship. The closer to 1 that the ISI is, the more sensitive your lab reagent is to differences in those vitamin K dependent factors assessed in the PT. So as I've already stated, the INR is used for warfarin monitoring. And it is best practice and international recommendations that the ISI, as well as the denominator, the geometric mean, be locally derived and validated. The other thing I want to bring to your attention is the INR is only validated between 1.5 and 4.5. All right, the reliability of an INR from any lab above 4.5 is unknown. All right, so the reality is we know in the lab that physicians use INRs greater than 4.5 for therapeutic interventions, but we do have to be cognizant of the fact that they may not be precise or accurate. Obviously, it's very high, so obviously you can take that away from it, but the actual number may or may not be accurate. So what is happening in the real world? Because the INR was brought in to be this international standardization for your warfarin monitoring of your patients. We continue, Dr. Lewis and I published a review article in 2017 that there continues to be unacceptable variability in the INR between laboratories internationally. And the main or the root cause of this variability is that laboratories setting the ISI and the mean normal prothrombin time, or the denominator of that PT ratio, is still variable and is not well done internationally. External quality assurance data is used to monitor laboratory performance over time, and it is a way for EQA programs to kind of monitor the effectiveness of the education and the harmonization strategies that are happening around the world. So the INR is not the magic bullet. There is still a lot of variability around the world. However, it is much more reliable than thinking of the PT in seconds between laboratories. Moving to the activated partial thromboplastin time, this is another commonly ordered core laboratory test. And the easiest way to remember what your PTT assesses is all factors but factor 7. So it is the contact factors as well as your prekallikrein and high molecular weight kininogen, and then all of your factors from 12 down to the generation of thrombin and the conversion of fibrinogen to fibrin. It is a two-step reaction where we have to pre-incubate the patient's plasma with the PTT reagent. It's not a long incubation. It's usually anywhere from 3 minutes to 5 minutes, but it is a standardized time depending on the reagent instrument combination in your lab. But we have to allow that 3 or 4 or 5 minutes in order to allow contact activation. So we need the contact activators to work with prekallikrein, high molecular weight kininogen, and factor 12 and move them all to their zymogen activated, from zymogens over to their activated form in order to participate in the coagulation. After that predetermined time, we then add calcium, and we're able to time for clot formation and give you a time in seconds. So the PTT is often used for monitoring unfractionated heparin or standard heparin. There is no relationship to therapeutic doses of low molecular weight heparin. So your PTT cannot be used for monitoring low molecular weight heparin. And we also have to be cognizant that depending on the reagent and instrument combination used in your lab, there are different sensitivities to unfractionated heparin, as well as to lupus anticoagulant, as well as to the various intrinsic factor activity levels, specifically 8, 9, 11, and 12. All right. So there's a lot of variability, and there's a lot of PTT reagents on the market. I would recommend that you understand the performance of the PTT reagent that you're using for your clinical practices. And your laboratory should be evaluating and have that data available to you on their reagent performance in unfractionated heparin patients receiving unfractionated heparin, as well as patients who are positive for the lupus anticoagulant, as well as what in vitro factor sensitivity curves, so that you know exactly at what point your PTT will go abnormal, depending on how low one of those intrinsic factors are. And the lab should be able to provide you that information. So for developing an unfractionated heparin therapeutic range does require that we take patients who are only on unfractionated heparin. So they're not on a secondary, they're not on warfarin or any other anticoagulant. And it results in where we run unfractionated heparin anti-10A levels, and we run the PTTs. So the anti-10As on the left of this slide, the anti-10A level is on your x-axis, and the PTT that we get is on your y-axis. And we do, it's just a simple regression analysis that I do, or that the person calculating the unfractionated heparin therapeutic range does. And we utilize that regression equation, and we are able to calculate the corresponding PTT in seconds to the therapeutic range. So in Hamilton, our therapeutic range for unfractionated heparin is 0.35 to 0.7 units per ml. So when I plug in the 0.35 and the 0.7 into the equation, you can see that mathematically we come up with a PTT of 62 to 92 seconds. So that would be the therapeutic range for this lot number of reagent. Ideally, your lab is not switching your PTT therapeutic range on lot numbers, so hopefully we see some stability between the manufacturers and their sensitivity to heparin. But this is how labs validate or verify the unfractionated heparin APTT range. In addition, we have available anti-10A and anti-2A chromogenic activity assays. Most commonly, laboratories do utilize the anti-10A chromogenic assay, and these are available commercially with either added antithrombin or without exogenous antithrombin. So there's two kits on the market. Again, I would suggest that you understand which kit your laboratory is using. Is there exogenous antithrombin or is there not? Because we already know that unfractionated heparin as well as low molecular weight heparin requires antithrombin for its action. So in kits that have exogenous antithrombin added, basically what you're measuring is how much heparin you gave the patient, because we're not seeing what is working in your patient, because the ones that do not add exogenous antithrombin is relying on the patient's antithrombin to allow that anticoagulant effect to be determined. So again, it's my personal opinion is labs should use them without exogenous antithrombin so that we're seeing how much is actually working in your patient as an anticoagulant. But again, that would be a medical director's decision for the lab that is running it. We do have commercial calibrators in QC that are need to be referenced back to the appropriate ISTH heparin reference plasma. This is just an example of what an unfractionated heparin anti-10A calibration curve looks like. So you have concentration on your X in units per ml. You have absorbance or color development on your Y axis. So if I have a lot of color at the end of the reaction, that means I had a lot of factor 10A left over, therefore not inhibited. So my heparin level is going to be very low. So it's an indirect measure. So the more color at the end of the reaction, the less anticoagulant we're detecting. So what is happening in Ontario? So the Institute for Quality Management in Healthcare, IQMH, that is headquartered here in Toronto, is responsible for proficiency testing in the province of Ontario. This is an OMA mandate. All right, so as of in 2021, there are 180 laboratories in Ontario and participating in these projects. We have a couple from out of Ontario, but the majority of this 180 are within Ontario. And the COAG challenges them on the PT-INR, the PTT, the thrombin time, the Klaus fibrinogen, and anti-10A levels. The anti-10As that IQMH challenges are the unfractionated heparin and low molecular weight heparin. As you can see on the bottom of this, very few laboratories offer you anti-10A levels for unfractionated heparin or low molecular weight heparin. Only approximately 10% of Ontario labs will offer you unfractionated heparin anti-10As, and only about 7% of Ontario laboratories offer low molecular weight heparin. So they're not very commonly performed, and these are mostly in our large academic centers. So in anti-10A, we used, sorry, I'm not on the committee anymore, but the committee uses the all methods mean. So we take the committee assesses all data from all methods, all reagent combinations, and the low molecular weight heparin anti-10A is very well performed across all laboratories. Again, very small number of laboratories, but it's very well performed. The unfractionated heparin historically was always assessed also by the all methods mean, except the challenges kept showing a lot of variability. And this variability was down to which kit the lab was using, which calibrator they were using. And this variability in the unfractionated heparin anti-10A was not only seen in Ontario proficiency testing, it's also seen in the international proficiency testing programs. So about 7 years ago, the committee moved, IQMH moved, that the assessment of laboratories are assessed on which calibrator they're used, all right? And this variability in the calibrator was actually independently confirmed by our group in Hamilton. And what we did in this, and I know this is a busy slide, but I apologize, just to focus you on the chart as a summary of what we looked at, is we actually brought in the WHO standard, all right, because you can get your hands on these standards out of England. And so we actually brought in the unfractionated heparin WHO standard. And we prepared, if you just go down that first column in the table, we prepared spiked samples of the various concentrations of unfractionated heparin in units per ml. And then we ran anti-10A levels with the only variable being the calibrator we use. So it's the same anti-10A kit and everything's on the same machine. So the only variable was the calibrator. And as you can see with these three calibrators, we get different results. The hepanorm, which is in the second column, was the one that performed closest to the WHO standard. The multi-hep calibrator, which coincidentally was from the same manufacturer as the hepanorm, showed a consistently lower recovered unfractionated heparin anti-10A. And then the third column, the third calibrator was a little bit off. It was higher at the high end and lower at the low end. So it really didn't make a lot of sense. But the reason I'm highlighting this is just to understand that each calibrator from the various manufacturers does perform differently. All right, so you do have to keep that in, but chances are you're using the same lab for your anti-10A measurement. So it's an internal consistency that you need. All right, so I think that was all I wanted to say on that. Okay, but do we need to monitor? There is some question as to whether we really need to monitor unfractionated heparin by the anti-10A method. And literally, Swangim et al. Just recently reported out a systematic review and meta-analysis on this, and this is like available electronically as of October the 15th. So we're talking literally 2 weeks ago. And what their conclusion was is that pooled data comparing the PTT or unfractionated heparin anti-10A activity for monitoring unfractionated heparin found no difference in the outcomes of bleeding or thrombosis. Okay, so, and again, we have to recognize that anti-10As are much more expensive than PTTs. All right. There's a lot of prep work that has to go into that validation of that unfractionated heparin APTT therapeutic range, but the PTT in and of itself is a much cheaper assay or less expensive assay for labs to run than it would to run an anti-10A. But there's always a but. All right, there's always a but, and that's what I always say to the residents. I said, this is how we do it, but. All right, so there's always a but in coagulation. So just to remind you that the APTT should not be used for monitoring unfractionated heparin when the PTT is not normal pre-heparin. All right, so if you don't have a normal, your PTT on that normogram is not going to be relevant. And that PTT may be abnormal for a number of reasons, such as a lupus anticoagulant, a very high factor VIII level. We know that that's an acute phase reactant, and a very high factor VIII level will shorten the PTT that the laboratory gets. And if there's an underlying coagulopathy, liver disease, factor deficiency. All right, so the PTT needs to be in the normal range in order to utilize those, or at least you need to be aware that the PTT was not normal when you're assessing your normogram. Less commonly, even chromogenic anti-10A levels are going to be impacted, not very often, but they can be by some pre-analytical conditions such as HIL interference, hemolysis, icteric, or lipemia in the patient sample. Okay, moving on to other anticoagulants. As we've learned already today, we all know that there's some, the DOACs are out there. The rivaroxaban, apixaban, edoxaban are all freely used. Dabigatran is also there. Less commonly, you might have some other direct thrombin inhibitors, argatroban or bivalirudin. But we do have other anticoagulants. And how does the lab help you with those? So as a reminder, in the DOACs, their effect on the routine coagulation testing that you're ordered is variable, all right? So the majority of patients on a DOAC will have an elevated PT and or APTT, but it is not in a linear dose response, all right? About a quarter of your patients on a DOAC will have no increase in your PT or PTT outside of the reference interval, all right? Doesn't mean they're not at the top end. I'm not suggesting that, but they're technically not outside of the reference interval. And there are different effects on the PT between the DOACs. So for instance, rivaroxaban and apixaban behave differently in the PT, with apixaban often showing no effect on the PT at all. All right. So just as a word, the PT and the PTT cannot be used to determine the degree of anticoagulation, but it may help you think that maybe there is some present, okay, but not an amount. So this is from the Thrombosis Canada Clinical Guideline, and it does have a nice summary table on the different laboratory tests and the effects of dabigatran and rivaroxaban and the anti-10As, rivaroxaban, apixaban, and edoxaban. So if you've not reviewed this clinical guide, I do suggest that is one that you might want to review, so you understand the general principles of what these anticoagulants do to your laboratory tests. Okay, but can the lab quantify? Yes, we can. All right, so monitoring your DOACs is not a recommendation. However, the labs are able to measure. Some labs are able to measure them, and we can, for dabigatran, we can use a hemoclot or a dilute thrombin time or an eccrine clotting time in order to monitor dabigatran action. For our rivaroxaban, apixaban, and edoxaban, we use the chromogenic anti-10A assay with drug-specific calibrators. All right, but as a word and as a general statement, very few Ontario labs offer DOAC levels. All right, and often these are not offered 24/7, even in the academic centers. But this is just to show you the quantitative assessment of the DOACs is extremely good when we use drug-specific calibrators. So on the left-hand side is dabigatran, and on the right-hand side is an example of apixaban. And you can see that the linear fit and the response is extremely reliable when drug-specific calibrators are used on the anti-10A for the apixaban or a dilute thrombin time hemoclot assay on the left. So you can see recovery is excellent. And these calibrators are HPLC calibrated. So they are a drug level because they are giving us a concentration of nanograms per ml. So as I said, monitoring the DOACs is not recommended. However, there might be some situations where you need to measure a level, and that might include if reversal is needed because of a bleed or urgent surgery, an overdose, a stroke on a DOAC, and you want to give the fibrinolytic agent. If there's an extreme in weight, renal dysfunction, malabsorption, or if you are looking at other drug interactions. All right, so in Hamilton, we've actually moved to 24-hour rivaroxaban and apixaban assays at our trauma cardiac site in order to ensure that we can offer those drug-specific anti-10As in a timely fashion so that we're not holding up lytic therapy. So just as a word, interferences, anticoagulants interfere with all clot-based assays. It's an anticoagulant, it's going to prolong our clot time. And depending on the anticoagulant, different lab tests show different impacts. So these are in our core tests. They're also in our factor assays. So we could potentially report out a falsely low factor assay if the technologist does not recognize the presence of dabigatran or an anticoagulant. And in fact, just yesterday we had a factors ordered and the patient was on dabigatran, and the technologist, you know, we had to note the dilutional effect because, and rightly so, the technologist caught that dilutional effect, and so the comment had to be amended. Not amended, had to be written in order before it was released. So falsely low factor assays is a risk, as well as in our thrombophilia testing. Depending on the method that is used for the thrombophilia testing, we could have a false result, either falsely high or falsely low. And realistically, we see almost 100% false positive lupus anticoagulant investigations when we receive samples from patients who are on DOACs. So as an educational piece a number of years ago, we have a bi-monthly HRLMP newsletter. And what we put out in this newsletter was a chart for our clinical partners in order just to summarize what the general effect of the 5 main anticoagulants that on those different test principles. So I'm not going to go through all of this, but you can see that we have the test, we have the principle of the test, and then we have the different anticoagulants and the impact that they would have. We went a step farther, and we also did this for our common special coag testing, our thrombophilia workups. Because again, even though thrombophilia lab testing is not recommended, and I'm not suggesting you send it, we do still receive a lot of investigations. And so this again was a piece of education in order where we put the principle of the different tests down the column, and then what the impact, because again, this is not generalizable to all labs because all labs use different methodologies and different principles. But it's just a suggestion that laboratories do have an opportunity to provide excellent education on the impact. So what can we do? Laboratories need mandatory and accurate anticoagulant information. Sampling from lines that contain heparin cause wrong results. Full stop. It's just a full stop. They're wrong, all right? And they often result in a second draw. We do need to follow best practice, clinical guidelines such as Thrombosis Canada's clinical guidelines, as well as Choosing Wisely Canada on when to test, all right? And we need education, all right? The Canadian Society of Medical Laboratory Science has released what we call Lab Wisely. And Lab Wisely is a free surface that you can actually put in the lab test name, and they will search Choosing Wisely Canada for you and come up if there's any specific recommendations related to that laboratory test. All right, so CSMLS, which I'm a proud 36-year member. Yes, I'm old. I am very proud of this initiative because we have been picked by Choosing Wisely Canada that they will put a bigger emphasis on laboratory recommendations moving forward. And they have involved CSMLS in committees in order to continue to get some education. So the very first lab-based Choosing Wisely Canada came out, oh my goodness, maybe a year ago. It's hard with the pandemic. I know my whole time frames have gone off, but it's about a year ago that there is, if you search Choosing Wisely Canada Laboratory Medicine, we now have 7 recommendations on that are directly related to laboratory. So very excited Choosing Wisely Canada is moving forward with that. So in summary, laboratories are able to monitor traditional and newer anticoagulants for clinical care. Those same anticoagulants potentially interfere with other lab tests. It's important when ordering lab tests that anticoagulant information is provided. And pre-analytical issues, it is the tip of the iceberg that we see, all right? But for instance, samples taken from a heparinized line or a port results in wrong results. End of sentence, okay? And we will need you to redraw or order a redraw. And education is key. There are resources out there, and we need to continue to dialogue with our labs and our clinical partners in order to share that. I do want to acknowledge Dr. Rita Selby for her review of my talk and valuable feedback and input, and I thank you for your attention.
Thank you so much, Karen.